Hi everybody, and welcome to my presentation on my medication administration timing study. So, a little bit about me. I have been a CNA for 6 years and a CMA for just over a year, and I've worked in 4 different facilities ranging from assisted living, skilled nursing, rehab, and dementia. And I have been in the long-term care field for a little over 6 years, and I have a long-standing interest in improving patient safety and efficiency in the industry. So a little disclaimer I placed in here for the facility staff because just to make sure that no data is leaked out. So a little bit of background. Medication administration is one of the largest tasks undertaken by nursing staff on a routine basis, and this means it consumes a significant amount of time in the day. And medications are the most common form of intervention in the long-term care field. There's little to no research conducted on medication administration in the long-term care, and research conducted partially in Oregon on medication administration in an assisted living found that the error rate can be as high as 28.2%, and of these 70.2% were wrong time medication errors. So this indicates that time is a significant issue when doing medications. Only one other study conducted in Canada, actually up in Ontario, attempted to quantify the time required to administer medications. This study did not account for error rates or shortcuts taken during the medication administration process, and many studies have identified an issue for nurses in the long-term care industry around time. The Oregon State Medication Administration rules were created with the 6 rights of medication administration in mind. The state has defined criteria about steps to be taken during medication administration, and I wanted to find out what the frequency and impact of using shortcuts would have on the time required in the medication administration process. From these criteria, a data collection tool was developed for the initial survey, and a standardized criteria was developed to evaluate if staff completed the different tasks. So here's the data collection tool that I created for the initial survey. And here's the results from the initial survey and the completion rate of each of the criteria. Some of the big ones are the checking medication labels 30% of the time. We're only doing it 30% of the time. And wearing gloves 50% of the time. Not touching medications 65% of the time. Basically, most of the criteria don't reach the 70% mark. During the initial survey, a significant result was found that to conduct the medication administration for one patient took about 9 minutes and 53 seconds. The average time to complete a pass was 2 hours and 54 minutes and 17 seconds. This is significant because that's 54 minutes and 17 seconds past the 120-minute window allotted for medication administration. Some discoveries during the initial survey was that all state criteria were met 0% of the time for any one individual at any time, and the time error rate was detected at 30%. Most state criteria were not meeting the 70% completion mark, and we're taking 10 minutes a patient almost, so that means you could only conduct the medication administration for 12 patients within the 120-minute window. During staff interviews, the most common response to the question of why aren't we meeting all the criteria was not enough time was spontaneously offered. Because of shortcuts taken, it is theoretically possible for an increased undetected med error rate. So, because of the initial findings, a secondary study was conducted to look at more of the implications of time required to administer medications, and because no other survey tools existed, I had to design and program my own data collection tool. So to the right is the data collection tool that I programmed, and it has the start-stop times for all the different medications, classifications, and the state criteria built in. Some nice things about it is it allowed for bias-free, precise instant timing. It was precise to the second and allowed for timing and classification of every medication, control for timing of patient variables, and time taken for different procedures. It also found the total time taken for each patient and was sensitive to multitasking, which the Canadian study was not. And it automatically calculated and tabulated into a Microsoft Access database. For the secondary survey, I wanted to take out how much time it took to do different types of medications and do different procedures, as well as perform the crush procedure for crushed medications. I also wanted to control for the patient variables, mainly in how they took their medications, because this seemed to be making an impact on the total time. I also wanted to control for distractions because distractions are associated for an increased rate of med errors. So I developed a classification system to count how many distractions or interruptions occurred during the administration process. Distractions and interruptions occurred on 64.62% of all medication administrations, with an average distraction time of 2 minutes and 26 seconds. Again, the state criteria were looked at, and the significant ones were that meds not handled by hands was almost 70% of the time, so a little bit of improvement. Checks all the medication administration records 50% of the time, and washing hands was only done 63% of the time. But we'll come back to this as it has a more significant factor later. So some of the results, we saw 65 patients receive their medications for a total medication N of 419 medications. 14 seconds for pills, 16 seconds from bottles. Preparations took 42 seconds, and narcotics took 1 minute and 4 seconds, and that's because of the signing out process it takes to check out Schedule II substances. For the different procedures, it was found that inhalers took 24 seconds, eye drops 42 seconds, applying patches like nitro or pain patches was 52 seconds, and to crush medications it took 1 minute and 35 seconds. So that's mixing it into the pudding or applesauce or whatever the patient's choice is. And to collect vitals, I suspect this time is a little large and could be shortened by just providing the equipment to the nurse or med aid, because most of that time was spent collecting the equipment. By method of taking was left with patient, 18 seconds. Taking the medications all at once, 59 seconds. Crushed medications, so spoon-fed to them, 1 minute 49 seconds. Spoon-fed means the pills were set onto onto a spoon and fed to the patient over a period of time, and one by one, 2 minutes 4 seconds. The average time for one patient was 6 minutes and 11 seconds, and the average time to prep the medications was 2 minutes and 11 seconds. The average time of travel was 59 seconds, meaning 30 seconds to the room and 30 seconds back. The average time for one patient does not equal the time plus the average time of travel. This is interesting because those two added together does not equal the average time for one patient. So there was another factor going on. I'm calling this factor the fatigue factor. It was discovered that staff slow down at a very predictable rate throughout the medication pass. This can be expressed mathematically as a function of patients completed. Here is a plot of the actual times taken by the individual staff members against the number of patients completed. And by plotting a line, you can see an exponential increase in time taken as different patients are completed. To take another look at it, I took a look at the initial survey and the time taken, and the same trend held true. After averaging together all the times taken by the staff, an exponential line of best fit was plotted and the equation was taken. And the equation is as below. Y is the time needed ATP is the average time per patient calculated using the number of items or procedures to be done and patient characteristics, and its R squared is 0.70. Time needed as a function of patients completed. This is a plot of the average time for each of the staff members against their patients completed. What is nice about that is that it predicted the time needed within a standard error of 14% on average, which translates to about 13 minutes, which is pretty insignificant in the grand scheme of things. But using the results from the Canadian study, the equation was able to predict the completion times within one standard deviation of their results. Coming back to the medication criteria, all state criteria were met 0% of the time for any one patient. The average time savings by not meeting their criteria was 1 minute and 31 seconds. And when you don't play by the rules, you receive a penalty. This graph shows the time taken, actual time needed in blue without the penalty, and the red is one with 1 minute and 31 seconds added to predict the time needed if all criteria were being met. With that, if you're meeting all the criteria, you can complete 11 patients on average inside the 120-minute window. At current practice, you can complete 14 patients on average inside the 120-minute window, difference of 3 patients. From the data, it can be determined that staff are under heavy time pressures, and normally when people are under pressure, they tend to make more mistakes. The average patient load is 22, and 30% of medications are given outside of the 2-hour window. Safety checks built into the state criteria are not being adhered to. The fatigue factor equation can be used as a tool to calculate adequate staffing, and it is sensitive to the individual unit characteristics. Better scheduling of medications decreases medication load during individual passes, and staff are not intentionally neglecting standards of practice, but are simply doing the best within the system they're within. It is important that we begin looking at the factors of time and fatigue on staff. Fatigue and time pressures are associated with an increased rate of medication errors. Only after staff have enough time to go through all criteria can the equation be further refined to improve its accuracy. Recommendations include calculating the number of bottled medications that can be rescheduled, assuming that all bottled medications are vitamins. This decreases the load on the morning medication pass and would increase the amount of patients that can be completed. Use the equation to calculate adequate staff needed to meet all standards of medication administration and provide safe, timely, and effective care to patients. Decrease the chance for interruptions by designating other staff to answer phones. Educate staff on the significance of interruptions and med errors, because this is a patient safety issue. Limitations of the study include it was not sensitive to some types of med errors: omitted dose, incorrect medication, or wrong patient. It is also limited by a small data set and is inclusive to only one facility. There is also no standardized method of prepping medications because this is an assessment of current practice, and this resulted in a calculated penalty. Predicted time is only valid if the staff follow all criteria. So if more time is allotted, it is only worth it if staff follow all the criteria set forth by the state. In future studies, it would be nice to look at implications of double shifts. Does the fatigue trend restart with each medication pass, or does the fatigue trend continue to slow over time? What implications does the number of work days in a week have on administration times? Are you going to be faster on the Monday compared to the Friday? After more time is allotted to staff, further refine the fatigue factor equation to improve accuracy. I'd like to thank all the people who helped make this project possible. Here's a couple of resources that I have used, and that is the end of the presentation.